only in Germany, it's also in Europe. Even last week, I had a 16-hour flight or overall travel time from Dublin to Leipzig. Hopefully you can hear me. Can you?
Yes, perfect.
All right, okay, now I start with my talk on the current and future treatment strategies in cardiogenic shock. So, yeah, these are my disclosures, mainly the funding we have got for the conductance of the randomized trials we have done and which we are currently doing in patients with cardiogenic shock. And I would like to start with a case which is maybe also helpful for the next speaker, for Veli. This is a patient with anterior STEMI. As you can see it here, he presented, or he had angina since 7 o'clock p.m. and several hours later he presented to our heart center with these data with blood pressure of 82/55 on a moderate dose of norepinephrine. He was tachycardic. He had elevated lactate. He also had elevated glucose, and he was centralized with cold skin and extremities. And this was a patient from our carpal shock trial. As you can see it here, he had acute occlusion of the LAD, severe stenosis of the left circumflex, and a chronic total occlusion of the RCA. If we have such a patient, we have to make several key considerations. First, is this cardiogenic shock? I think this is relatively clear. Then we have to ask the question, what is the severity? And this will be covered in the next talk. And then we also have to assess, is it predominantly left, right, or biventricular failure? And in the end, we also have to make or answer the question, what are the support options? And this is usually done LV, RV, or biventricular with echo or with a classic Swan-Ganz catheter. When we talk about cardiogenic shock, in particular after acute myocardial infarction, we have a good news that we went down from the previously 80% to nowadays maybe 40% according to registries. And if you look for the large-scale randomized trials, you can see it here, the mortality is somewhere also between 40 and 45%. However, the bad news is that since 20 years, we haven't seen any progress in the reduction of mortality, as you can see it here. It's still in the range between 40 and 45%, even in the most recent published carpal shock trial from our group. Regarding access site, if you take the patient to the cath lab, all the guidelines currently say it's a class 1A recommendation to use the radial access for STEMI, for non-STEMI, as well as for chronic coronary syndromes. And currently, however, cardiogenic shock is only used in less than 20%. This is from our carpal shock trial, where you can see this is adjusted that all-cause death or renal replacement therapy and all-cause death and renal replacement therapy can be reduced if you use radial access in comparison to femoral access. Further supporting that we should use it, however, we have no randomized trials currently in cardiogenic shock for the access side. Revascularization strategy, this is what we have addressed in our carpal shock trial. Roughly 80% of the patients have multivessel coronary artery disease, as you can see it here, from the large-scale randomized trials and registries. And we know from the shock trial that reperfusion, revascularization can reduce mortality. The question is for the 80% with multivessel coronary artery disease, what we should do. Carpal lesion only, carpal plus staged, CABG is also an option, or immediate multivessel PCI. And in the previous guidelines, it was a 2AC recommendation to perform immediate multivessel PCI in these patients with multivessel coronary artery disease in cardiogenic shock. However, evidence or level of evidence C means we do not know it, and that's the reason why we have performed the carpal shock trial, which has been located in all these countries in Europe, and it was also funded by the European Union, as you can see it here. And as you can see it here, there was an absolute 10% reduction in the primary study endpoint, all-cause mortality or renal replacement therapy, from 55 to 45%, which was highly statistically significant for carpal lesion only PCI in comparison to immediate multivessel PCI. And this was mainly driven by an absolute reduction of more than 8%. Number needed to treat of 12 to save one life. I think this is an impressive number. And this is also the reason why in the new guidelines, it is now a class 3 recommendation to not perform immediate multivessel PCI in these patients with cardiogenic shock and multivessel coronary artery disease. So this is a way to go, culprit plus staged. And you should not go for immediate multivessel PCI. There may be some exceptions based on anatomic or angiographic criteria. I already mentioned for the assessment of severity and the cause of cardiogenic shock, we can consider to use the pulmonary artery catheter, the Swan-Ganz catheter. And you all know this, this device or this catheter, which is in place for many, many years or maybe decades. However, data on this are really very limited. Veli will probably show you the data of the Sky Shock 2 definition, as you can see it here. For the assessment of severity, currently, it is recommended to use hemodynamics like cardiac index, pulmonary capillary wedge pressure, based on the Swan-Ganz catheter. You can see it here also for patients in stage D or E. It is recommended to use the Swan-Ganz catheter. However, if you look for randomized data, there's no mortality benefit. The problem with these randomized data, they are not derived from patients with cardiogenic shock. So there were all kinds of patients on the ICU, sometimes patients undergoing hip surgery. So we cannot really get evidence from these randomized data. Currently, we have some registry data recently published. You can see it here for patients in more severe Sky shock stage D and E. There is a benefit if you use the Swan-Ganz catheter. And there are also other data, but at least we have data from observational registries showing some benefit. Inotropes and vasopressors, we have this nice table from the American Heart Association scientific statement. You all know this from medical school, all the different receptors, all the different drugs. However, the evidence is really extremely limited on this. We have a subgroup analysis from SOAP2, which suggests that there's a mortality benefit with norepinephrine versus dopamine. However, the overall trial was negative. And we have this trial from France, from Bruno Levy, showing that epinephrine versus norepinephrine leads to same mean arterial blood pressure, same cardiac index. However, epinephrine leads to a higher heart rate, higher lactate or worse lactate clearance, and also to more patients with refractory cardiogenic shock. And that's the reason why this trial was stopped early by the Data Safety Monitoring Board. And if you look into the guidelines, they currently, for vasopressors, give a 2BB recommendation for norepinephrine, and for inotropes, currently, as you can see it here, this is a class C or level of evidence C recommendation because we do not have much randomized data. More recently, published last year in the New England Journal of Medicine, Mirrenone versus dobutamine in patients with cardiogenic shock, single center trial, all kinds of cardiogenic shock, not only patients with cardiogenic shock after an acute coronary syndrome. You can see it here for this, if you ask me, slightly unusual combined clinical endpoint, no difference. And there's also no difference for all-cause deaths, in-hospital deaths between Mirrenone and dobutamine. If you ask me, I go for the cheaper drugs based on this trial. I always go for dobutamine in case I need some inotropes. Last part of my talk will cover mechanical circulatory support. You all know all these devices which are currently available, at least in Europe, some of them, or the majority also in the United States. I do not show the Kaplan-Meier curves of IBP shock 2 because I've shown it so many times, but I give you the recommendations which are currently in the guidelines. It is a 3B recommendation to not use the intra-aortic balloon pump on a routine basis in patients with acute coronary syndrome and cardiogenic shock. There is a 2BC recommendation for mechanical complications and for patients, for example, as a bridge to destination or bridge to bridge in patients with other causes of cardiogenic shock. Our trial led to an increase in the use of active mechanical circulatory support, as you can see it here in the United States for Impeller tandem heart and also for ECMO. I personally believe this is a reflex. Intra-aortic balloon pump does not work, so we try to go for the more advanced and more active devices. Similar data here from Germany, as you can see it here. Intra-aortic balloon pump goes down. We are down to less than 10%. At the same time, increase in ECMO and also a steep increase in the use of impeller, as you can see it from these curves. Now we have to look behind it and looking for the evidence. The problem with that is the evidence is really extremely limited. We had the chance to do an individual patient data meta-analysis. We go back. No difference in all-cause mortality. Some benefits in mean arterial blood pressure, benefits in lactate. On the other hand, as a drawback, we had significantly more bleeding and a strong trend towards more limb ischemia. So some benefits on hemodynamics, on the other hand, more complications. And so probably we have to ask for the sweet spot. When we do not have large-scale randomized data, we usually go for match comparisons, which is the best approach, the next best approach in comparison to a randomized trial. So this is what we did. Impeller registry compared match comparison to patient from IVP shock 2. No difference in all-cause mortality with impeller in comparison to control. More complications with impeller, peripheral complications, more life-threatening severe bleeding, and more sepsis with impeller versus control. And then we had in 2019 two large-scale registries, one 28,000 patients, the other 48,000 patients presented at AHA 2019. I show you briefly the results. One registry showed higher mortality with impeller, more bleeding, more acute kidney injury, more stroke with impeller in comparison to intra-aortic balloon pump adjusted analysis, then very highly published. This analysis from Druva, altogether more than 3,300 patients, propensity matched impeller versus intra-aortic balloon pump, once again showing more death, more bleeding with impeller in comparison to control. Now, just a few words on ECMO. ECMO, very limited data, less than 100 patients, as you can see it here. It suggests, based on registry data, that there is a mortality benefit by 33%. In the current guidelines, it has been upgraded that we should use these devices. Honestly, I'm surprised, based on all the evidence, that we could have an upgrade from 2B to 2A, but this is a decision by the heart failure guidelines. Probably most important, if you ask me, this is why we also use it, is patient selection. If you put in such a device in a patient who would survive anyway, you will not change the outcome of the patient, but you probably may lose some patients because of complications. I'm convinced that maybe 20% have a benefit by these devices, but then there are also patients where you can put in the best device on the world and you will not change the outcome because these patients have hypoxic or anoxic brain injury. This is what we call cohort A, no device, cohort B, yes device, and here you can consider to use a device as a bridge to decision. I just, for the sake of time, I just skip this. ECMO venting, this is currently also what is currently discussed. If you use ECMO, you should surely avoid a fully thrombosed ventricle. There seems to be data on observational registries that venting has a benefit for these patients. We also did such an analysis, match pair comparison, ECMO versus ECMO plus impeller. Some call it ECMELLER strategy, where it suggests, based on this propensity matched analysis, that there is a mortality benefit if we combine it. We currently do a large-scale randomized trial. This is ECA shock, ECMO versus no ECMO in patient with cardiogenic shock. And now coming to the last two slides. Summary, what we currently have as evidence: revascularization can reduce mortality. Culprit lesion only PCI reduces mortality in comparison to immediate multivessel PCI. Norepinephrine, probably better than any other vasopressor. IBP currently or clearly no mortality benefit. And if we are using active mechanical circulatory support in an unselective way, currently we also do not have any hint that this may reduce mortality. And that's the reason why we need these large-scale randomized trials for patients in cardiogenic shock. Currently, in our ECL shock trial, we have a little bit more than 370 patients included. Euroshock, initially initiated from UK, all over Europe, has been stopped. And then we also have the danger trial. Currently, they have 299 patients.
We're going to have to move to your summary slide. I apologize. We're well over time. Okay.
Yeah, this is the last slide. As you can see, these are the numbers, and we will be able to present our results in the next year. And I hope that we will be able to do it at ESC. Thank you very much.